Good afternoon, students. So in today's session, we are going to address competency PH 1.35, that is, describe the mechanism of action, types, dosage, side effects, indications of the drugs used in iron deficiency anemia. So before that, we will briefly discuss anemia also. Coming to introduction, what is anemia? Anemia is a common clinical condition that is caused by an acquired or hereditary abnormality of RBCs or its precursors, or it may be manifestation of an underlying non-hematologic disorder like nutritional deficiency of iron. So it is defined as decrease in circulating RBC mass, and the usual criteria to label anemia as hemoglobin percentage if it is less than 12 gram per deciliter in humans, and if it is less than 14 gram per deciliter in men, then we can call it as anemia. And what are hematinics? So hematinics, these are the substances required in formation of blood, and they are used in treatment of anemias. And these substances, there may be deficiency of these substances in conditions like blood loss, which may be acute or chronic, impaired red cell formation, which may be because of deficiency of essential factors like iron, vitamin B12, folic acid, or in hypoplastic anemia like bone marrow depression, or because of erythropoietin deficiency in patients with chronic kidney disease. Also, anemia may be because of increased destruction of RBCs as in hemolytic anemia. And what is hematopoiesis? So it is the production of erythrocytes, platelets, leukocytes from undifferentiated stem cells from bone marrow. And for hematopoiesis, we need essential nutrients like iron, vitamin B12, and folic acid, as well as presence of hematopoietic growth factors. Now, anemia broadly it is classified because of anemia associated with decreased RBC production. For example, in cases like iron deficiency anemia, megaloblastic anemia, thalassemia, anemia due to chronic diseases and in renal failure. And second class is anemia due to increased RBC destruction, as in hemolytic anemia and sickle cell anemia. What are the chief signs and symptoms present in patients with anemia? So usually patient will not complain of any symptom until and unless hemoglobin is less than 7 or 8 gram per deciliter. And these symptoms, they are mostly non-specific, and these are like fatigue, headache, dyspnea, pallor, anginal pain, tachycardia, or visual impairment. There may be splenic enlargement or bony tenderness, blood loss in feces, or neurological symptoms may be present in some patients. Then, as we know, iron, it is an essential body constituent. Total quantity of iron in our body is approximately 4 to 5 grams, of which 62% is present in the form of hemoglobin in RBCs, 7% present in myoglobin, 6% present in various enzymes, while 25% is stored in the form of ferritin, hemosiderin in reticuloendothelial cells, liver, spleen, and bone marrow. So iron is required for hemoglobin production, and in its absence, small red cells, they are produced, and we usually call it as microcytic. And also hemoglobin levels, they are less in cells. That's why we call it microcytic hypochromic anemia. So in this picture, we can see in normal blood, RBCs, they are of normal size, as well as hemoglobin percentage in RBCs is good. But in anemic patients, we can see size of RBCs is reduced, as well as hemoglobin levels, they are less. So we can see much central pallor. That's why it is called as microcytic hypochromic anemia. Iron deficiency, it can occur because of either inadequate dietary intake, as in vegetarians, malnourished patients, or it may be because of loss of blood in women because of heavy menstruation, or it may be because when requirement of iron is more, as in conditions like pregnancy or in growing children, requirement of daily iron is more. And daily iron requirement in adult male is approximately 0.5 to 1 milligram, while in adult female it is 1 to 2 milligram. In infants, it's 60 microgram per kg. In children, 25 microgram per kg. And in pregnancy, especially during last 2 trimester of pregnancy, the demand for iron is more, and it is 3 to 5 milligram daily. Now, which are dietary sources of iron? So, rich sources, they are like liver, egg yolk, dry fruits, wheat germs, while medium sources, they are meat, chicken, fish, spinach, and apple. While poor sources, milk and milk products, contrary to earlier belief, they are poor sources of iron. Now, coming to pharmacokinetics of iron, how iron is handled within the body. So as we know, dietary iron, it may be in inorganic form or in organic form. In organic form, it is usually present in the form of heme in non-vegetarians. So this heme is readily absorbed from gastrointestinal or mucosal cells, and heme carrier protein is present on this luminal surface of these mucosal cells, which readily absorb this heme within the mucosal cells, while most of the dietary iron is present in inorganic form, that is ferric form. And it is important to convert this ferric form into ferrous form, and gastric acidity and presence of reducing agents helps in this conversion of ferric iron into ferrous form. Ferrous iron is then readily absorbed by transporter DMT1, that is divalent metal transporter 1 present on luminal surface of mucosal cells. Once this ferrous iron is get absorbed into the mucosal cell, it is again transported by another transporter FP1, that is ferroportin, which is present at basolateral membrane of these mucosal cells, and from there it is carried inside the plasma. If there is excess of iron present in GIT diet, then such ferrous iron in mucosal cells is converted to ferritin, and it is first converted to ferric ions, and they are complexed with apoferritin molecule and stored as a ferritin in mucosal cells. So if there is excess of iron present in diet, then such ferritin is stored in mucosal cells, and life of mucosal cells is of 2 to 4 days. After 2 to 4 days, these mucosal cells, they are shed, and it is also called as ferritin curtain. When excess dietary iron is present, it is stored as a ferritin in mucosal cells, while whenever the demands for iron is more in iron deficiency anemia, such stored form of ferritin is less, and this ferrous form of the iron is transported by FP1 transporter into the plasma. In the plasma, this ferrous form is highly active one. It is enzymatically converted to ferric form, and this ferric form binds to another glycoprotein in plasma, that is transferrin. So two molecules of ferric ions, they get bound to these transferrin molecules, and in the plasma, iron usually transports in the form of bound form along with transferrin. So whenever the demand of iron is more in bone marrow cells which are forming RBCs, that is in erythrocyte precursors, at that time transferrin receptors, they are more expressed on such precursor cells, and they readily get bound to this transferrin bound to ferric moieties. And once they are bound to transferrin receptors, the receptor and this complex is endocytosed. It is engulfed within the vesicles of the cells, and within the vesicles, because of acidic pH, these iron molecules, they are freed, and transferrin receptor, they are reutilized for further transport of iron. Again, if there is excess iron present in body, that is stored as a ferritin in reticuloendothelial cells, in liver, in bone marrow. So there are some factors which can reduce absorption of oral iron. So presence of acid or reducing substances like ascorbic acids or presence of meat, it facilitates absorption of iron from GIT. While there are few factors which can reduce iron absorption, like presence of alkalis, phosphates, phytates, then presence of tetracycline tablets, and presence of food can reduce absorption of dietary iron. Now, iron preparations, they are mainly divided into two forms, oral iron preparations and parenteral iron preparations. So oral iron preparations, they are like ferrous sulfate, ferrous gluconate, ferrous fumarate, colloidal ferric hydroxide, and carbonyl iron. So coming to ferrous sulfate, it contains 20% of elemental iron. Dry weight of ferrous sulfate in tablet is more. For example, it is in case of ferrous sulfate, approximately it is 32%. While elemental iron is important because elemental iron percentage is the iron percentage which get readily absorbed from GIT and that is available for absorption. So ferrous sulfate, it contains 20% of elemental iron. It is the cheapest one, but it is having metallic taste in mouth. So it is widely used because of it is a cheap one. Then second one is ferrous gluconate. It contains 12% of elemental iron. In people in whom ferrous sulfate is not tolerated, in them we can use ferrous gluconate. It is present in tablet form, while ferrous sulfate it is present in tablet, capsule as well as in syrup form. Ferrous fumarate, it contains 33% of elemental iron. It is less water soluble than ferrous sulfate and it is tasteless. So we can use it in place of ferrous sulfate for people who complains of metallic taste in them. The next one is colloidal ferric hydroxide. It contains 50% of elemental iron. Then similarly, carbonyl iron, it contains 100% of elemental iron. So this carbonyl iron, it is a highly pure metallic iron. It is present in very fine powder. Particle size is less than 5 micrometer. It is mainly prepared by decomposition of iron pentacarbonyl, which is a highly toxic compound. And it is claimed that it absorbs from intestine from longer duration and also gastric tolerance of this carbonyl iron is more. However, bioavailability of carbonyl ion is 3/4 that of ferrous sulfate. So slightly less bioavailability in comparison with ferrous sulfate. So while using these oral iron preparations, we have to remember a total of 200 milligram of elemental iron given daily in 3 divided dosage that produce maximal hematopoietic response in anemic patients. And while giving it in infants and in children, we have to calculate dose as per body weight and dose is 3 to 5 milligram per kg. And when it is used, these preparations, when they are used for prophylactic purposes, prophylactic dose is 30 milligram of elemental iron daily. And absorption is much better when these iron preparations, they are taken on empty stomach. However, their side effects, they are also more when we give them on empty stomach. So many physicians prefer them in giving in higher dosage after meals. So after meals, their GIT side effects, they are relatively less. Also, other adverse effects of these oral iron preparations are they are directly linked to the elemental iron content. If we increase the elemental iron content, the side effects they are also more. So mainly GIT side effects like nausea, epigastric discomfort, abdominal cramps, constipation, diarrhea, they are important one. Black stool. So constipation and diarrhea, both they are present, but frequency of constipation is more with these oral iron preparations. Also, metallic taste is an important side effect of all these oral iron preparations. Some important interactions of oral iron preparation. So, iron forms chelating compounds with tetracyclines, fluoroquinolones, penicillamine, methyl dopa, and levodopa. So, simultaneous administration of these drugs should be avoided. Otherwise, there will be less absorption of both the drug. Also, stable complexes of iron they are formed with thyroxine, capropyl, and bisphosphonates. So, we may need to increase the dose of thyroxine or capropyl or bisphosphonates if we are administering them simultaneously. So better to keep some space or a gap of 2 to 3 hours between administration of both these drugs. Now, other preparations, they are parenteral iron preparations. So indications for using parenteral iron preparations, they are either if oral iron, if it is not tolerated, or if there is failure to absorb this oral iron, like in patients with malabsorption, or if there is non-compliance to oral iron, or if there is severe deficiency with chronic bleeding, and if there is emergency to rapidly recover this parenteral iron store, body iron stores, also along with erythropoietin in chronic kidney disease patients. So these are indications during which we can use parenteral iron. So whenever possible, oral iron preparations, they are preferred over these parenteral iron preparations. And how much dose we have to give by parenteral route. So to calculate that dose, many formulas they are available, but most commonly used and simple formula to calculate total iron requirement is 4.4 into body weight into kg into hemoglobin deficit in gram per deciliter. So this formula is used to calculate total iron requirement, and this formula not only corrects anemia because of iron deficiency, but it iron stores which are required for it is also includes replenishment of iron stores also. So the formula is 4.4 into body weight in kg into hemoglobin deficit, where body weight is calculated in kilogram, while hemoglobin deficit is calculated in gram per deciliter. So examples of parenteral iron preparation, they are iron dextran, iron sorbitol citric acid, ferrous sucrose, and ferric carboxymaltose. So we cannot administer oral iron salt as it is because they are having protein precipitating nature. So iron needs to be complexed organically so as to use it by parenteral route. So these are 4 currently available parenteral preparations. We will see one by one. First one, iron dextran. So iron dextran is the oldest parenteral iron preparation. It is in use since last 50 years. It is a high molecular weight colloidal solution. It contains 50 milligram of elemental iron per ml, and it is the only preparation that can be given by either intramuscular or intravenous route. And while giving it intramuscularly, deep gluteal injections, intramuscular injections, they are given, and jet track technique is followed to prevent pigmentation, skin pigmentation. But we have to remember that this iron dextran, it is more antigenic, hence anaphylactic reactions, they are relatively more in comparison with other parenteral iron preparations. And other adverse effects of iron dextran, local side effects like pain at site of intramuscular injection, pigmentation of skin, then systemic side effects, they are like fever, headache, chest pain, dyspnea, a lymph node enlargement. These are some systemic side effects of iron dextran. Then second preparation is ferrous sucrose. So it is a relatively newer preparation. It is having high molecular weight. Basically, it is a complex of iron hydroxide with sucrose. That's why it's called ferrous sucrose. So it can be given only by intravenous route. It is safer and than the older iron dextran. So hypersensitivity reactions that are present with iron dextran, they are relatively less with this ferrous sucrose. Dose of ferrous sucrose is 100 milligram once a day or 100 milligram once a week. Maximum 200 milligram can be given in a single dose. So adverse reactions, they are relatively less in comparison with iron dextran, and that's why they are particularly indicated in patients of anemia in chronic kidney disease. But in them also renal damage has been observed because of this ferrous sucrose. So it also should be used cautiously in such renal damage patients. Then next is ferric carboxymaltose. So it is the latest formulation, parenteral iron formulation. So here ferric hydroxide core is stabilized by carbohydrate cell, and dose is 100 milligram given intravenously or up to 1000 milligram is diluted with 100 ml saline. We cannot dilute it with glucose. It can be diluted only with saline and infused intravenously slowly, taking 15 minutes or more. So anaphylaxis reactions with ferric carboxymaltose, they are rare. And other side effects, they are like pain at injection site, then headache, nausea, then hypotension, flushing, chest pain, they are infrequent. And ferric carboxymaltose is not recommended in children less than 14 years. So safety data in children less than 40 years is not available. That's why it is not recommended in children less than 40 years. The next parenteral iron preparation is iron isomaltoside 1000. So this is the latest injectable iron formulation for IV use, and it is available in India since 2016. It consists of iron bound tightly in a matrix of isomaltosine 1000. So after in IV injections, iron maltoside is rapidly taken up by reticuloendothelial cells, and then it is slowly released as per their requirement. So this preparation is less toxic because of tight matrix binding. So reticuloendothelial cells absorbs it and slowly releases the as per the iron requirement. That's why it's less toxic. So full iron deficiency can be corrected by a single short period IV infusion. So that is one another advantage of this preparation. So total calculated dose of iron can be given in single dose. That's why it is more convenient and cost saving for the patient. Then current status of this parenteral iron preparations. So currently ferric carboxymaltose and iron isomaltoside 1000 are the two most convenient and safest IV iron formulations. Also, we have to remember these iron preparations and their route of administration. So intramuscularly, we can give iron dextran and iron sorbitol, while by intravenous route, we can give ferrous sucrose, ferric carboxymaltose, and iron isomaltoside. And iron dextran can be given by both intramuscular as well as intravenous route. Now coming to uses of these iron preparations. So as a most common indication for this is iron deficiency anemia. So we know in developing country like India, ample amount of population is anemic, and nutritional anemia deficiency of iron is one of the reason. Also, there are other reasons like hookworm infestations or chronic illnesses or peptic ulcers that also cause anemia. So this is the one of the most important indication. So other indications for these iron preparations, as in prophylaxis in in cases of pregnancy, in chronic illnesses, in menorrhagia after acute blood loss, and in patients with megaloblastic anemia. So while treating iron deficiency anemia, we have to remember iron should be normally administered orally unless and until there is indication for parenteral iron. Oral preparations, they are preferred. Parenteral therapy is reserved for special circumstances, as we have already discussed. And after starting the treatment, a rise in hemoglobin level by 0.5 to 1 gram per deciliter per week is an optimum response to iron therapy. And it is faster in the beginning when anemia is severe. Later on, this rate of increase in hemoglobin percentage decline. However, we have to continue the therapy till normal hemoglobin levels they are achieved, and generally it takes 1 to 3 months to achieve this normal hemoglobin levels, and it depends on severity of anemia. And after that, we have to further replenish the body stores of iron, and further 2 to 3 months treatment with these iron preparations is required to restore body stores of iron. So these iron preparations can also be used for prophylactic purpose. Usually the amount of iron available from average diet and the absorptive processes in intestine place a ceiling on this iron absorption. So maximum 3 milligram per day iron may get absorbed from GIT. So usually in patients like in menstruating women or during latter half of pregnancy and in infancy, iron demand is more. So in such situations, if we do not supplement iron by these iron preparations, so iron deficiency anemia is very common. So in these situations, these mostly oral iron preparations, they are preferred. And prophylactic dose of iron is 30 milligram elemental iron daily. Also, in some other conditions, also like chronic illnesses, menorrhagia, acute blood loss, the prophylactic iron is required. Also, coming to acute iron poisoning. So it is more commonly seen in infants and children when they accidentally consume 10 to 20 tablets of these iron salts, or they consume any liquid preparation. And if dose of iron is more than 60 milligram per kg, then we can expect acute iron poisoning in such children. So manifestations of acute iron poisoning, they are like vomiting, abdominal pain, hematemesis, diarrhea, cyanosis, dehydration, convulsions, finally shock, then cardiovascular collapse and death. So sometimes death may be as early as within 6 hours. Okay. So pathological findings present in acute iron poisoning, they are hemorrhage and inflammation in gut, then hepatic necrosis and brain damage. Now, how to manage such acute iron poisoning? So management can be divided into three parts. First, to prevent absorption of iron from gut. So we can induce vomiting, or we can do gastric lavage to prevent further absorption of iron from GIT. So for gastric lavage, we use sodium bicarbonate because activated charcoal is not useful for absorbing iron on it. So sodium bicarbonate is used for gastric lavage. We can also give egg yolk and milk to prevent further absorption of this iron from GIT. Other mode of treatment is the iron which is already absorbed into the blood. So we can give a chelating agent like desferrioxamine, which is also a drug of choice in such patients. So desferrioxamine is given by intramuscular route, and its dose is 0.5 to 1 gram and repeated after 4 hours, 4 to 12 hours as per the requirement. Or it can also be given by intravenous route. Dose is 10 to 15 milligram per kg per hour till serum iron levels falls below 300 microgram per deciliter. Then such patients also require other supportive measures like fluid and electrolyte balance by administering IV fluids. And if there are convulsions, we can administer diazepam by IV route. So that should be administered cautiously. Then chronic iron toxicity or hemochromatosis or hemocytosis. So here skin is bronze or gray because of iron overload. Also there is pancreatic damage because of iron overload, and it leads to diabetes, which is called as bronze diabetes. So treatment in such chronic iron toxicity is phlebotomy. 450 ml of blood is taken out by venesection. So that is, we are removing 200 milligram of iron from the blood. Also, in some cases, we can use desferrioxamine can be used. So this is briefly regarding treatment of iron deficiency anemia and treatment of acute and chronic iron poisoning. Thank you.